This conference will now be recorded.
Good morning all. Today we are going to discuss about bronchial asthma. Before going to the topic bronchial asthma, respiratory disorders are mainly classified into obstructive and restrictive. Obstructive due to due to restriction. Bronchial asthma is a type of obstructive disorder. Bronchial asthma. It is defined as chronic inflammatory disorder of airways due to increased responsiveness of lower airways to multiple stimuli. It is reversible obstruction. It can range in severity from mild without limitation of patient's activity to severe with limitation of activity. If it present for days or weeks, it is known as status asthmaticus. Risk factors and triggers involved in asthma. These are endogenous. Endogenous factors like genetic predisposition due to genes ADAM33 and atopy and airway hyperresponsiveness, gender, females are most commonly affected, and ethnicity, blacks and whites, obesity, and early viral infections. And environmental factors like indoor allergens, which are like household dust, outdoor allergens like pollen, occupational sensitizers like fumes, metal fumes, paints, and passive smoking, respiratory infections like rhinovirus, diet, and acetaminophen. Triggers are mainly allergens, upper respiratory tract viral infections, exercise and hyperventilation, cold air, sulfur dioxide and irritant gases, and drugs like beta blockers and aspirin. And due to stress and irritants like household sprays, paint fumes. And coming to atopy. Atopy is genetic predisposition to develop specific IgE antibodies directed against environmental allergens. It is an identifiable risk factor for asthma. Triggers are like pollen, fungal spores, nuts, air pollution, cold air, laughter, and perfumes. Next, coming to the most common hypothesis, hygiene hypothesis. It tells that lower level of infection during childhood is an increased risk for asthma. So mainly Th2 subtype of cells are involved in allergic phenomena. A later exposure to infection will shift the predominant protective to Th1 immune response. Coming to the pathophysiology, three main features are involved in the pathophysiology. One is airway inflammation, airway obstruction, and bronchial hyperresponsiveness. Coming to the pathogenesis of asthma, when antigen like pollen or household dust or any drugs like aspirin uh, or when a household dust like when patient exposed to that, it will be presented to the antigen presenting cell like dendritic cell, and from dendritic cell through lymph nodes, it is carried to T lymphocytes. In T lymphocytes, they are activated to T helper cells are activated to Th1 and Th2 response. Th1 mainly secretes interferon gamma, lymphotaxin, interleukin 2, and Th1 response is mainly involved in cell-mediated immunity and neutrophil inflammation. Th2 mainly involved in allergic response. It leads to stimulation of IgE, which in turn activates mast cells, basophils, eosinophils. These mast cells, basophils, and eosinophils will secrete the mediators of inflammation like histamine, prostaglandins, leukotrienes, enzymes. These mediators are responsible for bronchial hyperresponsiveness and airway obstruction. Due to bronchial obstruction and airway hyperresponsiveness, we will develop these asthmatic symptoms. Same pathophysiology. After antigen like pollen, house dust might, in a sensitized patients, elicit the production of IgE type of antibodies, which remain either circulating in blood or attached to the mast cells of nasal or bronchial tissues and basophils. On re-exposure of the same antigen, The resulting antigen-antibody reaction in early phase causes degranulation of lung mast cells and releases the bronchoconstrictors like histamine, serotonin, prostaglandin D2, and cystinoid leukotrienes like B4, C4, and D4. Mast cells also release the interleukins like 4, 5, and 30, which are responsible for the delayed phase. And other mediators involved in delayed phase are like adenosine, neuropeptides, which secrete mucus and responsible for more and also leading to increased permeability. And this is the normal respiratory epithelium. In patients with bronchial asthma, we will see in epithelial there will be increased eosinophils and globular cell hyperplasia and macrophages in lamina propria, and there will be hypertrophy of smooth muscle and increase in number of CD4 T lymphocytes and Th2 T helper cells in lamina propria. And this is the picture showing normal airway and in airway of asthmatic patients. In patients with asthma, the airway will be narrowed and the smooth muscle will constrict the airway, and the smooth muscle will be thickened due to inflammation, and there will be obstruction due to mucus plug. And coming to the difference between extrinsic asthma and intrinsic asthma. Extrinsic asthma means there will be an identifiable cause, whereas intrinsic means there won't be any cause. And extrinsic asthma is most common, whereas intrinsic is less common. Associations like atopic disease, eczema, allergic rhinitis. Coming to the pathogenesis of extrinsic asthma, it is IgE mediated mast cell degranulation, whereas intrinsic is due to intrinsic mast cell instability. Age of onset, extrinsic asthma is most early onset, whereas intrinsic is late onset. There will be a precipitating factors for extrinsic asthma like allergen can be identified by positive screen prick test. There will house dust mite, pollen, and mouths. For intrinsic asthma, there will be drugs like NSAIDs, aspirin, cold air pollutants, emotional stress, and exercise. Coming to the clinical features. The most common clinical features are dyspnea, coughing, and wheeze. This will be worse at night and will be and in early mornings. There will be prodromal symptoms like itching under the chin, discomfort between the scapula, and inexplainable fear. Coming to the classification of severity, it is classified into 4 types: mild intermittent, mild persistent, moderate persistent, and severe persistent. In coming to the mild intermittent, the symptoms will be less than 2 times a week, and there will be night symptoms less than 2 times a month. And lung function, based on spirometry assessment of forced expiratory volume and peak expiratory flow rate, we will categorize the severity based on lung functions. For patients with mild intermittent, the lung functions FE1 or peak expiratory flow rate will be less than 80% predicted. For mild persistent, the symptoms will be more than 2 times a week, and nighttime symptoms will be more than 2 times a month, and lung function will be more than 80% predicted. For moderate persistent, there will be daily symptoms, and patient will be using inhaled short-acting beta-2 agonists, and exacerbations may affect the activity. There will be more than 2 exacerbations per a week. Nighttime symptoms will be more than 1 per week, and FE1 or peak expiratory flow rate will be more than 60 to 80% predicted, between 60 to 80. Coming to the severe persistent, there will be continuous symptoms, and there will be limitation of physical activities and frequent exacerbations. Coming to the nighttime symptoms, they are most frequent compared to the other classes, and the lung function will be FE1 or peak expiratory flow rate will be less than 60% predicted. Coming to the diagnosis, we mainly diagnose by clinical history supported by spirometry readings of forced expiratory volume V1 more than 15% will increase following the administration of bronchodilators or corticosteroids. And the diurnal variation will be more than 20% on more than 3 days in a week for 2 weeks on PEF diary. We should ask patient to keep one diary and record the events like how many exacerbations he will be having per a week, per a month, and per a year. And if even will be more than 50% will decrease after 6 minutes exercise. Other investigations like sputum eosinophilia, exhale nitric oxide levels, sputum prick test, bronchial provocation test. Coming to the radiological examination, mainly X-ray will be almost normal. We can't rule out the patients with bronchial asthma with other respiratory disorders. If we suspect any bronchiectasis leading to bronchial asthma, it can be identified by HRCT scan. Coming to the management, mainly the aims of asthma treatment are to, to minimize the chronic symptoms, mainly nocturnal episodes, and to minimize the exacerbations, and to reduce the emergency visits, and to minimize the use of beta 2 agonists, and no and to reduce the limitation, mainly exercise, and reduce the peak expiratory flow rate by less than 20%, and to minimize the adverse effects from drugs. Coming to the drugs used in asthma. The drugs used in asthma are classified into controllers and relievers. Controllers, these are the drugs which are used to control the long-term, these are the drugs which affects the long-term survival and which will control on a long-term basis. These are inhaled corticosteroids like glucocorticosteroids like beclomethasone, budesonide, and fluticasone. Long-acting beta-2 agonists like salmeterol and formoterol, and anti-leukotrienes like montelukast, zafirlukast. Coming and chromoprons like cromolyn and nicorandil sodium, and anti-IgE like omalizumab. And relievers, these are used in emergency basis. When patient arrives to you with breathlessness, and we have to immediately relieve his breathlessness, we'll use these relievers to relieve dyspnea. These are short-acting beta-2 agonists like salbutamol, levobuterol, terbutaline, and perbuterol. Anticholinergics like ipratropium and oxytropium, and short-acting theophylline like aminophylline, epinephrine, and adrenaline. Generally, we don't use this epinephrine and adrenaline for normal cases, but only in patients with status asthmaticus. Coming to the stepwise approach of treatment according to the recent guidelines. First, any patient who present with asthma, first we should classify based on his severity and how many episodes in a year, in a month, in a week. Then according to the history and based on the pulmonary function test, we will treat the patient in a stepwise manner. First, we'll treat with a short-acting beta-2 agonist as and when required. Like when the patient has symptoms, we will use this beta-2 agonist. If patient is not controlled with this beta-2 adrenergic agonist, then we will add inhaled steroids like beclomethasone, fluticasone. Generally, these drugs are used in a dose of 200 to 800 micrograms per day if for an adult. Coming for children, we'll use less than 400 micrograms per day. Next, if patient is not controlled even with these inhaled steroids, then we will add long-acting beta-2 adrenergic agonists. Even if the patient is not controlled with this beta-2 adrenergic agonist, then we will go for theophylline, sustained release theophylline, or leukotriene receptor antagonist. Even if patient is not controlled with these drugs, then we will go to inhaled steroids. Will increase the dosage of inhaled steroids. In step 2, we are using a dosage of 200 to 800 micrograms. Now we will increase that dose. We will go for 800 to 2000 micrograms per day. To this, we can add leukotriene receptor antagonist or theophylline. Even if patient is not controlled with these drugs, then we will go for steroids, oral steroids. In first 4 steps, we are using inhaled drugs. Now we will go for oral steroids. Or increase the doses of inhaled corticosteroids more than 2000 microgram per day. This is the treatment strategy. while mild persistent will start with beta 2 agonist whenever the patient is having symptoms. If it is not controlled, like in mild persistent where there will be more frequent symptoms, we will add ICS, low dose. Even with ICS, if the symptoms are not controlled, we will go for low dose ICS along with its long acting beta 2 agonist. Even though it is not, the symptoms are not controlled with long acting beta agonist, then we will go for long acting beta agonist and will increase the dose of inhaled corticosteroids. Even though we increase the dose and usage of long acting beta 2 agonists, the symptoms are not controlled, then we will go for oral corticosteroids. uh, Level of asthma control. This is very important to know whether the patient symptoms are controlled with that medications we are using, or we should escalate the doses, or we should change the medication. This we will come to know this by assessing the level of asthma control. Level of asthma control is mainly by based on the symptoms, daytime symptoms, limitation of activities, nocturnal symptoms, need for rescuer or reliever treatment, and based on the lung function and number of exacerbation. For controlled patients, the daytime symptoms will be less than or two per week, and there won't be any limitation of activity, and there won't be any nocturnal symptoms, and there is no need of using rescuer or reliever treatment, or he might use for two or less than two times per week, and lung function will be normal, and there will be no or mild exacerbations. For partially controlled, the daily symptoms will be more than twice a week, and there will be mild limitation of activity. Maybe mild nocturnal symptoms may be present, and he might be using the rescuer treatment for twice a week, and lung function will be less than 80% predicted, and exacerbations will be one or more per year. In uncontrolled, he will have more number of day symptoms. There will be limitation of activity and nocturnal symptoms three times a week, and he might be using the rescuer treatment more than three times a week, and there will be exacerbations one time in a week. Coming to the pharmacotherapy, these are the drugs which are used. These are bronchodilators, leukotriene antagonists, mast cell stabilizers, corticosteroids, and anti-IgE antibody, which is the main culprit in atopy and which is the main thing responsible for the bronchial asthma. Bronchodilators. These are short-acting and long-acting. Short-acting are salbutamol and terbutaline, which are used on a rescuer basis for immediate control of symptoms. Salbutamol and terbutaline are used mainly to control immediately to relieve the dyspnea. And long-acting like salmeterol, formoterol, bambuterol. These are the long-acting drugs which are used as an add-on therapy in moderate persistent, severe persistent. These categories we are using these drugs, these long-acting beta-2 agonists. Coming to the methylxanthines, these are theophylline, aminophylline, and doxophylline. And coming to anticholinergics like ipratropium bromide and tiotropium bromide. Leukotriene antagonists like montelukast and zeferlukast, and mast cell stabilizers like sodium chromogranate and ketotifen. And corticosteroids, these can be used systemic and inhalation. Systemic mainly used for very severe persistent. These are hydrocortisone and prednisolone. Inhalational are beclomethasone, dibromide, budesonide, fluticasone, cyclisonide, flunisolide, and anti-IgE antibodies like omalizumab. Coming to the mechanism of action of beta adrenoreceptor agonists, mainly they act on beta. They stimulate the beta 2 receptors, leading to increased adenyl cyclase, leading to increased cyclic AMP, which in turn leads to bronchodilation. And they also inhibit the release of mediators from mast cells like histamine, serotonin, leukotrienes, which are mainly responsible for the pathogenesis. And it also increases the mucous clearance by increasing the ciliary activity. Coming to the mechanism of action of theophylline. These are methylxanthine derivatives, and that they mainly inhibit phosphodiesterase enzyme, and they also block the adenosine receptors, and they increase the endogenous catecholamine release, and they also interfere with the receptor operated calcium channels and decrease the calcium levels, and they mainly have anti-inflammatory action. Coming to the muscarinic antagonists. These are M1, M2, M3 subtype in the airway. These muscarinic antagonists act by blocking M1 and M3 and causing bronchodilation. Ipratropium bromide. It binds to all receptors and inhibits acetylcholine-mediated bronchospasm. This is the picture showing how the drugs act on bronchial tone. Coming to the mechanism of action of glucocorticoids. They mainly act as an anti-inflammatory and by blocking the synthesis of arachidonic acid by phospholipase A2 and reduce bronchial reactivity. They also increase the responsiveness of beta adrenoreceptors in the airway. They provide the long-term stabilization of symptoms due to their anti-inflammatory effect. Inhaled glucocorticosteroids along with beta-2 agonists are the first choice drugs for chronic asthma. Glucocorticoids inhibit the release of prostaglandins and leukotrienes, thus prevent smooth muscle contraction, vascular permeability, and airway mucus secretion. They also produce eosinophenia, which prevents the cytotoxic effects of mediators released from eosinophils. Glucocorticoids also enhance the beta-2 adrenergic response by upregulating beta-2 receptors in lung cells and leukocytes. This is the picture showing how corticosteroids act on the synthesis of prostaglandins. In membrane lipid, there will be phospholipase 2 enzyme which converts arachidonic acid into lipoxygenase, and arachidonic acid is converted by two enzymes, lipoxygenase and cyclooxygenase. In lipoxygenase pathway, they are converted into leukotrienes B4, C4, D4, which act on the receptors. Xylotine acts on these lipoxygenase enzyme, whereas zafarlukast inhibit the binding of B4, C4, D4 leukotrienes to its receptors. Coming to the cyclooxygenase pathway, it was mainly inhibited by NSAIDs, where by the action of cyclooxygenase, arachidonic acid is converted into endoperoxides, prostaglandins G and H. Prostaglandins G is converted into prostacyclin I, prostaglandins E and F, and thromboxane A. Leukotriene receptor antagonists. These are zafarlukast, montelukast, and pranlukast. These are selective and reversible antagonists of cysteine leukotriene receptors, which are taken orally, and these are the bronchodilators and have anti-inflammatory action. These are less effective than inhaled corticosteroids. They have glucocorticoid sparing effects. This is the picture showing the action of leukotrienes C4, D4, E4 on cysteine L1 receptors. And coming to the mast cell stabilizers like chromoline and neurochromil, they act by stabilization of mast cell membrane. So they prevent the secretion, they prevent the release of mediators like serotonin, histamine, which are responsible for bronchoconstriction, increased permeability, and increased number of eosinophils. So by stabilizing the mast cell membrane, chromoline inhibit the release of mediators. They can be given by inhalation, aerosol route, and they have a poor oral absorption. Coming to the omalizumab. This is a monoclonal antibody which is directed against human IgE, which is the main antibody responsible for the pathogenesis, which in turn activate the mast cells basophils. It prevents IgE binding with its receptor on mast cells and basophils and decrease the release of allergic mediators and used for the treatment of allergic asthma. It is very expensive and it is not a first line therapy. This is the picture showing how omalizumab binds to the IgE antibody. Coming to acute severe asthma, also known as status asthmaticus, where the patient presents with cough, wheeze, and shortness of breath, and chest wall recession. Like means chest wall recession means indrawing, and unable to complete a sentence in one breath. And there will be use of accessory muscles, and respiratory rate will be more than 30 per minute, and pulse rate will be more than 120 per minute, and there will be pulses paradoxes in severe asthma. And peak expiratory flow rate will be less than 60% of the predicted, and on auscultation the chest will be silent. We can't hear any respiratory sounds, which is seen in acute severe asthma. And uh, and it will be treated by 40 will be treated with 40 to 60% oxygen to maintain saturation more than 95%, and salbutamol 5 mg or terbutaline 10 mg will be used in nebulized form. In mild exacerbation, 2 to puffs every 3 to 4 hours will be sufficient. For moderate exacerbation, 6 to 10 puffs every 1 to 2 hours. Or ipratropium, which is anticholinergic. It can be used in a dosage of 0.5 mg to the salbutamol nebulizer every 6 hours. Or next, we can use prednisolone tablet 0.5 to 1 mg per kg, or hydrocortisone 200 mg through IV route to reverse the inflammation and improve the recovery. If patient is unresponsive to salbutamol, ipratropium, and prednisone, then we can go for magnesium sulfate IV, used in a dosage of 2 grams. Coming to how we will use this beta 2 agonist in inhalational route, there will be one we'll use by rota inhaler. We should instruct the patient how to use this rota inhaler. First, there will be one mouthpiece and one and a cylinder which fits in. There will be one and a drug which will be fitted in that cylinder. We should clean that mouthpiece, and we should keep the mouthpiece into the mouth. For that, patient should take a deep breath, and keep the mouthpiece into that mouth, and press that releaser, and the drug will be deposited. And at the time of, we should instruct that patient should take deep inspiration, and we should also instruct the patient after taking this beta 2 agonist, he should wash his mouth to prevent the fungal infections. Okay, thank you.